All right, everybody. We have a provocative topic today. We're talking about best practices and what are we doing with post-procedural anticoagulation after WATCHMAN or LAO procedures. And I think this is kind of a black box right now. I feel like, and I'm sure you feel the same way, Elliot, like we're where we are with dual antiplatelet therapy after stenting. There's so many trials in so many different directions that it's kind of hard to know what a consensus is, and everyone's kind of doing this differently. So I think it's important just to kind of pour through the data and talk about, what does the data show? What can we do for our patients to give them the lowest risk of bleeding and the lowest risk of DRT? So, Elliot, welcome, brother. How are you?
Great, thank you. Yeah, this is a good topic. I do agree with you completely that I think if you go to 10 different places, you might see 10 different strategies. But there's
Yeah.
certainly you've got to hone down in on what's best for the patients and safest, of course.
And I think there's a lot of misconceptions because I think once we got on label for dual antiplatelet therapy after LAO, I think a lot of people went to that. And I know we did, but then we started seeing more bleeding, we started seeing more DRT, and so we're now back to kind of where we started. So I think it's important to just talk about that a little bit. And Elliot, I'm sure we'll talk about what you guys are doing at Sutter. But just in terms of considerations, like what is the issue? It's just like stenting. We're balancing bleeding risk, which is especially high in these patients, and we're balancing DRT risk. And nobody wants a DRT, nobody wants bleeding. And so how do we kind of mitigate the risk of both of those things together? And then what were they on before their left atrial appendage occlusion? Patients don't want to switch. You're trying to get these patients off their blood thinner. The last thing you want to do is start something new, or they have to start paying $400 a month because then they're in the donut for their DOAC. So we have to consider patient-specific factors. And then when are we imaging? Because that's going to impact our level of comfort with switching patients to aspirin monotherapy, something like that. So I think these are all things to consider when you're trying to evaluate your own post-procedural LAO procedure. Um, in terms of kind of what the historical precedent is, I think the PROTECT trial was, the first WATCHMAN trial. Elliott's the master of clinical trials, so I'll defer to him on some of this. But, I think a lot of people are kind of stuck on this 45 days of VKA or DOAC, and then you do kind of the 6 months of DAPT, and then you do aspirin. But, I think this space has really evolved from here. Kind of current on-label U.S. drug regimen is 45 days of DOAC plus aspirin, and then 6 months of DAPT, and then single antiplatelet therapy with aspirin with a 45-day and 1 year imaging. But I think what most high-level LAO operators have switched to is this Champion AF protocol, because I think it makes a lot of sense. And the majority of folks in Champion AF did DOAC monotherapy for 3 months. They stopped it. They switched the patients to aspirin. And then at 120 days, they did the imaging and continued aspirin if there was no thrombus on that. So, I think this regimen, and we'll go through the data why, but I think this regimen probably makes the most sense. Number one, we know that DOAC versus all these other things is just as good, if not better, in all the data. I think 3 months gives you a little bit more time for that device to endothelialize and heal in than 45. I mean, we know from some of the autopsy studies that, when you look at these patients, the device does tend to be endothelialized around 90 days. And then I also think it gives you that kind of comfortability where at 120 days after they've been on aspirin for a month, it makes you feel comfortable they're not going to get DRT because they've already been switched to single antiplatelet therapy. So I don't know, Elliot, what do you think of this regimen? Is there any benefits to other regimens that you've looked at? What are you guys doing? What's your thoughts on this?
Yeah, I mean, I think there's a couple things. I think it's a very good regimen, and by the current standard of practice, you can't go wrong with this. I think the questions that will be answered soon through the Simplify trial, which we're unfortunate enough to be a part of, will be: do you need the aspirin, or is the NOAC DOAC enough? And then two is can you do a lower dose DOAC? So that's
Yeah.
what that trial is testing: aspirin versus DAP versus a reduced dose DOAC followed by then just aspirin monotherapy. So that's going to be really interesting to see, because I think in the end, I'm cautiously optimistic what we'll do moving forward is just a reduced dose NOAC or DOAC for 3 months and then just aspirin monotherapy. But we'll see.
Love it. So can you go through? So it's a simplified trial. So there's three arms
Yeah,
after Watchmen. And what are the three arms again?
aspirin monotherapy, DAPT followed by aspirin monotherapy. So DAPT for 6 months, followed by aspirin monotherapy. And the last group is 3 months of reduced dose DOAC, followed by aspirin monotherapy.
Got it. Yeah, that'll be compelling for sure. Because I mean, this is a space, like we said, that there's a lot of data, but not a lot of it is prospective randomized controlled trials with intention to treat on a drug regimen. So I think that's going to be important. So that's great. Awesome. I'm looking forward to that. This is kind of a patient-specific algorithm. I have a couple issues with this, but essentially this is looking at where you split patients into 3 categories. Either they're prohibitive bleeding risk, in which case you either do no treatment or single antiplatelet therapy. They're ineligible for short-term full-dose DOAC, in which case you either use low dose, like you alluded to, Elliott, or DAPT. Or if they're eligible, you just consider DOAC, and if they're on Coumadin, you keep it, and then you image and go to aspirin. So I think this is actually a good kind of way to think about it. I disagree with the DAPT in the patients ineligible for short-term, because I think, as I'll show in the subsequent slides, we know that DAPT has a higher bleeding risk. And so if you're really trying to minimize bleeding risk, I do not think DAPT is a good option. I would rather do single antiplatelet therapy. And I've been doing ticagrelor, actually, because I think it's lower bleeding risk than aspirin. And you don't have to worry about the Plavix resistance issue, or low-dose DOAC. So, I mean, what do you think about these patients that are quote-unquote ineligible for short-term full-dose DOAC, Elliott? What would you say would be an ideal regimen for them if you're thinking about it?
I mean, we try to never put people on DAPT anymore because of the data showing that the DRT rate's higher, bleeding risk is worse or the same. So I try to either kind of negotiate with because usually the neurologist is telling, I mean, that's from my experience, I don't know about you, that's who's telling me no DOAC, it's the neurologist. And they don't really, this is not their area of expertise. So I usually either, if I feel super strong, I'll even go to them, or I'll do some kind of negotiating tactic where I'll say, okay, we'll reduce the dose and we'll put them on aspirin too. And they're usually okay with it. Very, very, very rarely do we do DAPT anymore. I mean, it's probably less than 5% of patients, just because of the data that you're going to show. Because it's worked out okay, knock on wood.
I think, that's a good point. I think the neurologic stuff is the stuff that gives the most interventional cardiologists pause to put patients on DOAC. So, like, for instance, a common complaint is a fall with a subdural hematoma, right?
Yep.
I think if it's a fall-induced brain bleed, then I'm comfortable putting them back on short-term DOAC. If it's something that's spontaneous, or they have amyloid angiopathy, those are patients I really worry about. But again, I'm not sure DAPT is better in them. I really don't. So I think this is definitely an area that needs to be explored, like super high bleeding risk patients, especially neurologic stuff. What do we do? But
I don't
again,
know that we know.
No,
I mean,
we
it's
don't.
tough, and we talk about it with neurology, but yeah, that I should have specified. I mean, talking about exactly what you're saying, the spontaneous bleeds, the falls in a subdural, or the cerebral amyloid angiopathy. That latter one is the most difficult to deal with. I never know what to do with those people, because basically the neurologists always tell us, if you put them on anything, they're going to bleed, and you're just like, okay, well, they're also going to have, their CHADS VASC is 7.
Yeah.
Something has to happen.
They've all had a stroke, so they all get
exactly.
the
It's just magically.
Yeah. Well, so I think there's been 3 pretty high quality studies looking at DAPT versus DOAC. The first was by Sam Reinhart. That was an NCDR analysis. The second, Julie Mesner, it was an early non-procedural bleeding examination that was a multi-center trial. And then there was a network meta-analysis, which is highly cited by Carvalho, looking at all of the data on this and kind of consolidating it, which I think is really elegant, a little beyond my grasp of statistics, but I'll show these kind of 3 studies. So the first is this Reinhardt study. So if you look at this, this is a comparison of DAPT and DOAC versus DOAC plus aspirin. And you can see pretty much across the board, DOAC beat DAPT in terms of major adverse events, major bleeding, stroke or TIA, and DRT. So I think this is pretty compelling that compared to DRT, DOAC is far superior in terms of these outcomes. It's a little hard to explain the mortality. I'm sure it wasn't powered for that, but a pretty consistent signal across all of these. When you look at the early non-procedural bleeding paper, again, this was a multi-center study, they showed that for all-cause death, patients that bled after WATCHMAN had pretty bad outcomes. Their all-cause death was significantly higher. Again, there's some confounding. These patients are sicker to begin with. But when you look at it, one of the strongest predictors of early non-procedural bleeding, again, is DAPT. with pretty reasonable hazard ratios of 1.61 and 2.31 in terms of early. And so, I think we all worry about DRT, and, DRT sucks. We hate having to put patients back on their DOAC. But this is a real problem. And they found in this study that about 7% of patients will bleed in that kind of 90-day window after WATCHMAN. And, I think we're obligated to really try to minimize that risk of bleeding. So I don't know. Thoughts on this, Elliott? Have you had a lot of bleeds after WATCHMAN? Because we don't see a lot of these patients because we do the WATCHMAN and we say it looks great, perfect seal, you're doing great, and we kind of send them on their way. But is this something that you've encountered with DAPT?
We have not had a large, at least my feeling, because I, like you said, I don't know that I'm seeing every patient all the time, not had a lot of issues with post-procedure bleeding. But when it does happen, it's bad.
Yeah.
Because then you're kind of this rock and a hard place situation. But I certainly think that the DAPT patients that we've seen have not done any better. And the people who have bled, it's quite that, prior GI bleeding is a predictor of early major non-procedural bleeding is seems like a no-brainer, but it is true. If the patient has bled before, particularly GI bleeding, and they've had a workup and they've said, oh, we're not sure, there was this small little ulcer and it wasn't bleeding at the time, put them on a PPI and let's see them back. Those people bleed again a lot because it's probably some small bowel AVM or something that no one knows they have, because people are just getting EGDs and cols. They're not getting push enteroscopies. So yeah, I think, and that's the whole issue with LAC. That's where all the naysayers, the naysayers have been quieted a little bit over time. But the biggest thing they've said is, well, the bleeding rates are the same. If you look at the early, Protect Prevail, overall bleeding rates were not different. The difference was that it was post-procedural bleeding versus, intra-procedural bleeding. We've done a really good job of taking care of the procedure part of that. The procedure is so much safer now than it was before. Our rate of pericardial effusion, we've had one in the last 300 cases we've done. And that was my fault. But, it was definitely mine. But, in general, it's very safe. But now we need to work on making sure that we don't precipitate bleeding after the procedure, because then you've really accomplished very little.
Totally. And like we've learned from the stent data, when patients bleed, the first thing your body inherently does is make yourself hypercoagulable, right? And so when you bleed, and especially when you stop your blood thinner as you're bleeding, you're hypercoagulable, and that theoretically will increase your risk of DRT. So I do think, I think stopping and doing what you can to mitigate the risk of bleeding is really important. And so in this analysis, DAPT was a strong predictor of early non-procedural bleeding. And that's borne out in our experience too. When we went to DAPT on these patients, we saw a lot more patients bleeding, and our nurse practitioners would call us and say, hey, Mrs. Jones has got bloody noses again, or is bruising everywhere. And, it's not just the big bleeds, it's also the big nuisance bleeds that people try to get away from this in the first place. So, and then the last one, this is a very busy kind of central illustration here, but really just kind of the crux. This is 41 studies, almost 12,500 patients. DOAC had the lowest all-cause mortality, and DAPT had fewer thromboembolic events than single antiplatelet therapy, but kind of far and away the winner from this network meta-analysis. And this is nice because you can actually compare these little columns, and you can look at DOAC versus DAPT, you can look at DOAC plus SAPT versus DOAC. It allows you to kind of compare all these drug regimens, but pretty consistently when you try to balance the risk of major bleeding and device-related thrombus, DOAC was superior to pretty much all of them. And so I think this really lends credit to the idea that, DOAC monotherapy seems to be the preferred modality for these patients, and maybe in the future low dose, and I'll show that data as well. But 3 pretty consistent signals across 3 different trials with various study designs showing that DOAC was superior to DAPT. So I think that door is kind of not necessarily closed, but closing in terms of DAPT as an option. So what are DRT risk factors? I never thought about this, but for those patients that are high bleeding risk patients, I think it's important to know these. So kind of the patient you're thinking about putting on single antiplatelet therapy, or you don't want to have the conversation about putting them on Eliquis, I do think it's important to understand, who are the patients that I'm worried about for DRT? Because we do kind of know all these patients in the lab when you see them, the ones with the smoke in the left atrium and everything just kind of looks like it's ready to clot in there. But, so LV dysfunction, prior stroke, permanent AFib, age, obviously, always a risk factor, and then large implants and deep implants. And so I think one thing you can do to optimize your procedural results and reduce your risk of DRT is really try to get that muffin top or champagne cork that we talk about a lot in our videos, and not deploy these deep, because you really get this kind of nasty laminar layer of thrombus. So anything that you don't see on here, Elliott, or how do you take into consideration these risk factors when you're trying to decide on post-procedural anticoagulation? Or do you?
I do a little bit. I think sometimes you got to be careful with these kind of things because this is very similar to when people were using the DAPT score
Yeah.
when some people took all these factors from trial and retrospectively made this score, and then when they prospectively tested the DAPT score, it was useless.
Yeah.
Not, I don't want to say that and offend somebody, but not
IBA is
terribly
critical.
useful. It wasn't necessarily applicable prospectively. I think for me, the main ones on here are we do know that from the EP literature that AFib puts you at a higher risk. So we always used to think. I remember when I was a cardiology fellow, they'd say, "Oh, it doesn't matter if you're an AFib for 5 minutes or all day, your stroke risk is the same." And we've now learned that that's not true. Um, the more you're an AFib, so that's definitely one. We would never do DAPT in permanent AFib or long-standing persistent patients who are in AFib. The deep implant thing, I think, is also a real thing too. We went exclusive. We will do these implants that we think look great, but in the 135, you're a little deep, and we'll bring it back a little bit. I think it also gets better expansion of the device. That might have something to do with it. If the
Yeah.
fabric is kind of pleated because you're over compressed, that really allows the top of the device to really expand and be kind of a smooth thing. So to me, those are the big ones. Um, hypercoagulable disorder, obviously, if you're more prone to clot, you're more prone to clot. But I think of this list that jumps out at me the most. And then mitral valve disease. I think that's the one thing that's not on there. If they
Yeah.
have any degree of mitral stenosis, then it's not technically what we term we don't use anymore with valvular AFib. If you just have, say, mild MS. Um, but it's, those people, to me, have been at higher risk. I think two of the DRTs we've had have been in patients with like mild to moderate calcific, that kind of nasty MAC
Yeah.
MS that's just acquired, not rheumatic.
No,
So that
absolutely.
would be the only one on here that I have experienced.
Yeah, and I think these are just important to consider when you're trying to make this decision because, like I said, I don't think there's one size fits all for this decision, but I do think it's important to understand, the risk factors for bleeding and DRT and trying to balance those. And I think it's also important when you talk to the patients, when you're consenting them, I always mention the risk of DRT because, the whole purpose of doing this procedure is to get them off a blood thinner. And so I always try to have that conversation and give them some percentages on the risk of DRT and kind of how we manage it. So I think it's important to set expectations about that up front. Do you talk about DRT much when you're consenting your patients, Elliott?
I didn't used to, and then I had a couple, and the patients were not super pleased that I hadn't mentioned it. So I started.
Yeah.
Fortunately, it worked out for those people, and but yeah, no, I do now, like you. I think because that's the whole point. You're telling them we're going to get you off blood thinners, and you need to deliver on that.
Yeah. Happiness equals reality minus expectations, bro.
Yeah.
It's a life-changing mantra. So anyway, just DOAC versus VKA, pretty similar. So I think my takeaway from this is that if they're on warfarin, I'm not going to switch them to Eliquis for 3 months. It just doesn't make sense. I think the data is pretty comparable for VKA and DOAC. And if, the only patients I still have on warfarin are usually my vets that come over and they've been on it for 30 years and they just kind of finally want to get off of it. So that's kind of my takeaway from this. We don't see a lot of these patients anymore, at least in my experience. And then, there are a lot of ongoing RCTs. Elliott mentioned the simplified trial, but there's a number of different regimens being compared. We got DAPT versus SAPT, short-term DAPT for 3 months versus SAPT, short-term DAPT versus low-dose DOAC versus, so just all the iterations. Hopefully we'll get some more data out of this. Hopefully it won't just confuse the issue more like we've seen with some of the PCI literature, but there's a lot of ongoing RCTs. One of the most interesting ones, like you mentioned, Elliott, is this low-dose DOAC. This is there's not a lot of data on this. This was a small, actually randomized trial, though, of WATCHMAN patients who got half-dose oral anticoagulation versus kind of standard antiplatelet thrombotic therapy. And so you could see that, when you look at kind of their standard antithrombotic therapy, and I can actually look and see what that is. I can pull up the paper, but overall, pretty positive outcomes for low-dose DOAC. When you look at all the kind of endpoints you'd worry about, device-related thrombus and major bleeding. So I do think this is emerging as kind of a happy medium. Are you guys doing this in your practice, Elliott? You mentioned it earlier. Are you incorporating low-dose DOAC a little bit?
We have done it a couple of times. We only really do it though, to be honest, in patients who otherwise qualify, if that's the appropriate dose,
Yeah.
right? If some 90-year-old who's got CKD or something, and so they qualify as a 2.5 of apixaban kind of patient. I have done in a few people also the 15 milligram dose of rivaroxaban with clopidogrel.
Got it.
That's a favorite of mine overall, just for post PCI patients who who need a DOAC. I actually feel like that regimen works quite well and has a pretty lowish rate of bleeding.
So just looked it up, and essentially the comparator arm for the low-dose DOAC, that was 45 days of full-dose DOAC plus aspirin, and then 6 months of DAPT, and then aspirin. So that was kind of the comparator, which is kind of the standard on-label anticoagulation. So pretty compelling, I think, for low-dose DOAC. And then lastly, just kind of take-home points from poring over this literature a little bit and looking at it. I personally think the champion AF protocol, which is DOAC mono for 90, followed by aspirin, and then imaging at 120 is probably best practice based on data for most patients. I think DAPT versus DOAC, I don't think there's a lot of questions about this, but there's been multiple pretty solid studies showing that DOAC wins with the lowest bleeding and DRT compared to DAPT. I don't think there's a huge role for DAPT based on the data. And then for high bleeding risk patients, instead of DAPT, I really think you should consider single antiplatelet therapy or kind of this emerging trend of low-dose DOAC. And then lastly, if they're on Coumadin, it's probably okay to keep them on Coumadin for another 90 days, plus or minus aspirin. So anything you'd add to this? I mean, just from the literature we've gone through, Elliott, is there any other take-home points you think, or do you think this kind of captures it?
No, I think it's great. I think it's a stay tuned kind of thing, like you mentioned. As more and more data comes out, hopefully it doesn't do, the PCI issue to us, where no one knows what to do anymore because there's a different trial for every med, a different range of time. I do think one important thing that you put in here, and that we should mention just on imaging. I know this is an imaging talk, but I think it's very important that people image after they're off whatever their kind of first line regimen is.
Yes.
So if you're doing a DOAC, however long you're doing it for, do your imaging at least like a few months after. Because they did it, this is all a relic of Protect and Prevail, where they were imaging frequently. But, there was a different device then. There was much more peri-device leaks. There was much more device-associated thrombus, much more procedural complications. So, but now what we're really looking for, particularly in most of the implants where we know we did a good job at the time, is DRT. And you can't, what is the point of looking for DRT if you've had your patient on a DOAC, a full dose DOAC for, a few months? You're not really going to see it. You're going to see it 3 months later. So to me, delayed imaging is a really important thing.
No, I totally agree, dude. I mean, it's like doing a left main, and not that anyone does surveillance angios anymore, outside of a couple people who we both know. But, there's no point in doing a surveillance angiogram at like 2 weeks, right? Like if you're going to do a surveillance angiogram, you're going to do it when the restenosis window is peaking, 6 to 9 months. So I totally agree. Why image if they're already on a DOAC? It's not really going to tell you much. I mean, it's pretty hard to get DRT on a full dose DOAC. Certainly possible, but unlikely. So yeah, I think you can really get all the information you need, especially if you image after they're off whatever kind of full anticoagulation you put them on after. So I think that's a really, really important point, Elliott. So, all right, great. So closing thoughts, anything that you would add to what we've talked about? Simplify, look out for that trial. Any other trials you can think of, Elliott, that are going to be kind of game changers in this space?
No, I think that's the biggest one right now. I think that one's going to really give us a very strong signal as to whether or not that reduced dose DOAC is a viable option for patients, and I look forward to enrolling as many patients as I can.
Is that actually enrolling? Because I know some of these trials have been really hard to enroll in, like ASAP and all that stuff. Has that been enrolling pretty well, or has it been a challenge?
We literally just got our paperwork finished like a couple of days ago, so we haven't enrolled anyone yet. I don't think we'll have that hard of a time enrolling because the thing is, everyone gets an implant. ASAP was so hard to enroll in because there was people in that trial who weren't getting, the control arm was no WATCHMAN. But in this trial, everyone's getting a device. So that's really what because it was the referring community that made the ASAP hard to enroll in. But in this situation, it's just because do your referring doctors ever ask you what regimen you're going to put on? They don't ever ask me.
Yeah.
They just care that the patient gets a WATCHMAN safely.
Yeah, successful WATCHMAN. That's all.
Yeah, so I think as long as because that's the strength of this trial. So I don't anticipate we'll have a hard time enrolling.
Yeah, I want to talk about equipoise, man. It's a perfect space to do clinical trials on, and it's not sexy, and it's not really going to like result in some groundbreaking new device approval or drug, but
No.
it's very practical and pragmatic, and I think this is a really important space to understand. So,
Yeah.
Awesome. Well, Elliott, thank you so much, man. We'll link to both a high yield post for this video, and then we'll get some shorts out of it, and hope everyone enjoys it. All right, take care.
Thanks, guys.